So let us continue our discussion with the topic pigmentary disorders. So we are going to very quickly see all the important previous year questions related to pigmentary disorders topic in this video. Watch this till the end, and if you like this concept of making the rapid revision videos, please do that like button. So without any further delay, let us continue the discussion. So basics of the skin pigmentation, which you have to remember. So the pigmentation of the skin, if it is in the epidermis, then we are going to see the skin to appear brown or black in color, and if it is because of the pigment in the dermis, then the color of the skin is going to be blue, slate gray or purple or violaceous in color, and this is because of the concept of Tyndall effect leading to the different light scattering. Coming to the epidermal versus dermal pigment, so we have already seen the color. So on Wood's lamp examination, if the pigment is in the epidermis, then there is going to be accentuation, or the Wood's lamp light is going to show the prominence when compared to the rest of the surrounding normal skin. Whereas if the pigment is in the dermis level, there is not going to be any such accentuation. Classic examples for the conditions having the pigment in the epidermis: melasma, I hope you remember this, which is also called as Chloasma in the pregnancy, freckles and Becker's nevus. Coming to the melanin in the dermis, so you should remember dermal melanocytosis, Mongolian spot, nevus of Ota, nevus of Ito. These are the three conditions which you have to remember. First, let us cover the disorders of the hyperpigmentation, that is melasma or chloasma in the pregnancy, where there is going to be increase in the function of the melanocytes, which are going to produce the more melanin pigment triggered by the UV radiation and also certain hormonal fluctuations, especially the thyroid hormone, right? And this is also called as mask of pregnancy or chloasma, and this can be associated with the OCPs and also the phenytoin usage. So see for these clues given in the question, associated with hyperpigmentary changes over the face, especially over the malar area, forehead and also over the nose in a symmetrical distribution fashion. Treatment of this condition: strict photoprotection, sunscreen should be used, and the drug of choice is this Kligman's regime, in which we are going to have three important medications, topical medications: hydroquinone, tretinoin and topical steroid. Prolonged use of hydroquinone is going to produce exogenous ochronosis. You should remember this point, which is also very important, right? Chick sign, this is a very important sign seen in the patients having chikungunya fever previously, where melasma like hyperpigmentation can be seen over the nose. Very important AIMS question. Differences between freckles or ephelides and the lentigines: freckles melanocyte number is going to be absolutely normal, whereas in the lentigines, remember, the number of melanocytes is going to increase, or we call it as hyperplasia, right? And effect in the summer season is going to be very important differentiating point. So freckles are going to darken in the summer season and they are going to fade in the winter season, whereas the lentigines, the color is going to constant all over the body throughout the year. Remember, the lentigines can occur even on the sun protected areas. And what is important association of the lentigines, it is Peutz-Jeghers syndrome, where mucosa also can have the lentigines along with the trunk, and also you remember they are going to be polyps in these patients. Coming to the freckles, important association is xeroderma pigmentosum, and also you should remember neurofibromatosis type 1, in which we are going to classically see the axillary freckling, which is called as Crowes sign, CROWES, Crowes sign. Coming to the melanocytic nevus, just remember few important points. Whenever you see this term neva, it simply means they are the aggregations or nests of the melanocytes, and the number of the nevi, not the specific type, primarily determines the risk of malignant transformation. This is also one important point to remember, right? Coming to the types of acquired melanocytic nevus, so you should remember junctional nevus, the compound nevus and the intradermal nevus. These are the three types in which we are going to see. The junctional is going to obviously present at the dermoepidermal junction. The nest of these nevi melanocytic aggregations are going to present at the dermoepidermal junction. It's going to present as a flat pigmented lesion, that is pigmented macules will be there over the body. Coming to the compound nevus, here patients are going to present with dome shaped papules which are deeply pigmented, right? And it's going to be at the junction as well as the dermis. Coming to the intradermal, so it is going to be as the name suggests, in the dermis this melanocytic nevus is going to be present, and it is flesh colored, that is skin colored papular lesions will be seen. There will not be any pigmentation as such. Okay. Now coming to the Becker's nevus and the dermal melanocytosis. So these are the two important things which you have to remember, which are localized pigmentary disorders. So in the Becker's nevus, remember, though nevus term simply means that it is a birthmark or a mole, but Becker's nevus, yes, it can be present during the times wherever the levels of androgens are very high, that is during the puberty. This is one interesting point to remember. It is acquired nevus and it is epidermal, like we have already seen that, and it's going to be presenting as unilateral brown patch on the shoulder or also over the chest, and also it is associated with the increased hair growth, and also the acne can be present over the site of the Becker's nevus. Coming to the Mongolian spot, deep dermal arrest of the melanocytes migrating from the neural crest. The same pathogenesis is also seen in the nevus of Ota and nevus of Ito. So congenitally, the patients, the children are going to present with blue, slate gray color over the lumbosacral area. And the good news is that it is going to resolve spontaneously. There is no any worries that it will be present lifelong over the body. Nevus of Ota and nevus of Ito, they are having some problem because they are not going to resolve spontaneously. Nevus of Ota, remember Ota ophthalmology. So here the involvement is going to be present over the face, and that to involve in the first and second division of the trigeminal nerve, and sclera also can be involved. And if the nevus of Ota is present bilaterally over the face, it is called as nevus of Hori. Now coming to the nevus of Ito, again it is present over the shoulder or the upper arm. The color is going to be blue, very very important color which you have to remember. Congenital melanocytic nevus, if it is more than 20 centimeters and it is present over the trunk area, it's called as bathing trunk nevus, and it is going to carry a high risk of malignant melanoma. We should monitor these patients very carefully because they may develop melanoma in the future. Some systemic and the drugs which can induce the hyperpigmentation. So systemic causes Graves disease, scleroderma. If you remember, scleroderma patients are going to have both hyperpigmentation as well as hypodepigmentation juxtaposed over the same area, and this is what is called as salt and pepper pigmentation. Very important previous year question. Steroid excess can also produce pigmentation. Pregnancy, you all know the changes which can happen, linea nigra and all. Pernicious anemia, Peutz-Jeghers syndrome, Addison's disease, arsenic poisoning, renal failure. So these are all the other ones, and also drugs. Few drugs which you have to remember which are very very important. The anti-leprosy medication clofazimine can produce coppery red brown discoloration over the body. Amiodarone, minocycline can produce bluish discoloration over the face and acne scars respectively. Silver, argyria, arsenic, raindrop pigmentation present especially over the palms and soles. All of these are very very important. Of course, bleomycin you can add upon. Bleomycin is going to produce flagellae pigmentation over the body. Coming to the disorders of the hypo or depigmentation. Congenital depigmentation disorders, the first and foremost one which you have to remember is obviously the albinism, which is a genetic autosomal recessively inherited condition because of the defect in the tyrosinase enzyme, which is a rate limiting step in the melanin production. Here remember the melanocyte number is going to be normal, but the problem is with the melanin production which is not happening, because of which the skin is going to be depigmented, and also eyes can be affected, iris can be affected, and there can also be other symptoms other than the skin, that is nystagmus and also photophobia. Even the hair can be completely white in color. These patients are going to have a very high probability of development of squamous cell carcinoma, and also there can be associated Chediak-Hikashi syndrome if there is a list gene defect. Palbaldism, it is an autosomal dominantly inherited condition. The problem is in the neural crest. The migration of the melanocytes happens from neural crest cells, and it is defective in this condition, where there is going to be melanocytes which are absent in the affected areas. And the important area which you have to look for is the forehead, which is called as white forelock, and also you can see that the areas of the depigmentation over the body are going to have this islands of the normal pigmentation, which are called as islands of the normal skin. And remember, the very important differentiating point between paludism lesions and vitiligo is going to be the paludism. The patients are going to have the depigmented changes over the skin from the birth, whereas vitiligo is an acquired depigmented disorder. Very important differentiating point. Coming to nevus depigmentosus or nevus acromicus, here the congenital patch of hyperpigmentation will be seen because of the problem in the melanosome transfer to the keratinocytes from the melanocytes. If you do a diascopy, it is not going to help you to differentiate between one more type of nevus, which is called as nevus anemicus, nevus acromicus, nevus depigmentosus. The lesion border is not lost, and there is no difference between the before the diascopy and after the diascopy. Right, it remains distinct. And coming to nevus anemicus, remember this is not a melanin disorder. It is basically due to the excessive vasoconstriction in the lesional skin because of the alpha receptor dysfunction, making the skin appear pale in color. That's why, because something related to blood is causing this hypopigmentation, that's why it is called as anemicus, nevus anemicus. And if you do a diascopy, the lesion border merges, so that we can not differentiate between the involved skin and the adjacent normal looking skin. So both of them are going to merge, and this is going to produce, the reason is because the surrounding skin is going to be blanched because of vasoconstriction, and lesion is already having vasoconstriction, because of it which it is appearing pale in color. So both these areas are going to merge, and we cannot differentiate between the normal skin and the involved skin, right? Next condition is a vitiligo. So here remember, the problem is autoimmunity, which is destroying the melanocytes. So if you do a biopsy, the lesion is not going to show any melanocytes. Typically it is due to the T cell mediated autoimmunity, resulting in the chalky white depigmentation, which is going to appear as completely depigmented macules. And important associations of vitiligo, because it's an autoimmune condition, other autoimmune conditions like thyroid dysfunction, Hashimoto's, Graves disease, type 1 diabetes, pernicious anemia, and also alopecia areata could be the important associations for you to remember. And what are the important clinical types? Segmental, non-segmental, and focal types. Segmental, remember the involvement is going to be unilateral, one side in a dermatomal pattern, and the rapid initial growth will be there. When the entire dermatome is affected, then the condition is going to become stable, and it will not cross the midline because it is following the dermatome. Very important points to remember. And also one more point you can add on: treatment in the segmental vitiligo is going to be with the surgery. Surgery is going to be the treatment which is used. Non-segmental, that is vitiligo vulgaris, which is the most common variety, is going to present as symmetrical patches over the body. Acrofacial, the involvement of the face and also the extremities will be there. Universal, if the vitiligo is affecting more than 90% of the body surface area. So what are the important clinical signs to remember? Wood's lamp examination is going to produce the accentuation of the skin color. That is ivory white color, it is going to appear very white in color. The skin is going to glow. Koebner's phenomenon, it is also seen in the case of the psoriasis, lichen planus. Another condition is vitiligo, which is also called as isomorphic phenomenon. New lesions are going to appear along the lines of the trauma because of the underlying autoimmunity. Leukotrichia, remember the hairs are also going to be affected in these patients, where there's going to be white hair produced, and these patients are going to have a poor prognosis because the repigmentation of the skin can occur because of the melanocytes which are safely present in the normal black hair. But because these patients are having white hair, there are no melanocytes which can produce a repigmentation of the skin, so poor prognosis is there. And coming to treatment, if the involvement is less than 20% body surface area, we can use topical corticosteroids as a drug of choice, and also we can use the tacrolimus for the sensitive areas of the face. But if the involvement is more than 20%, then we cannot obviously use the topical agents, then we are going to use the narrow band UVB. And stable vitiligo, like I have told you, surgical skin grafting melanocyte transfer is going to be used. in patients who are having universal vitiligo, where we cannot repigment the involved vitiligo skin, we can produce the depigmentation of the normal skin, which will then become depigmented, and we can see the entire body of same color, and that is achieved with the help of the MBEH, monobenzyl ether hydroquinone, which is going to cause destruction of the melanocytes. Now some of the other acquired hyperpigmentary conditions which you have to remember. So vitiligo, you have already seen that. Pityriasis alba, remember this is a type of eczema, so it is associated with atopy, especially seen in the children, and it shows mild hyperpigmentation with faint fine scaling. That is the reason why pityriasis term is used. Pityriasis, whenever you see, remember it is associated with scaling. What are other pityriasis which you can remember? Put your answer in the comment section below. I will tell the answer at the end of this video, and if you do a KOH, it's going to be negative. Pityriasis versicolor, you have already got one of the names. Yeah, it is associated with Malassezia globosa, Malassezia furfur. And if you do a KOH, what are you going to see? They are going to see spaghetti meatball appearance. And if you do a wood slam, it's going to show yellow fluorescence. PAH, post-inflammatory hyperpigmentation. Next one is chemical leukoderma. Remember, monobenzyl ether hydroquinone can be present in the rubber of the slippers, which can produce the destruction of the melanocytes, leading to the white colored skin, which is called as chemical leukoderma. PTBP, paratertiary butylphenol, which is present in the bindi, can also produce this destruction of the melanocytes, leading to whitish discoloration of the skin, chemical leukoderma. And also even the hair dye PPD can also produce this chemical leukoderma. So I hope this video was helpful. If so, please hit the like button, and also do subscribe for more such videos on a regular basis. If you have any doubts, please put your doubts in the comment section. And what is the type of the pityriasis which I was discussing in the video? Pityriasis rosea, pityriasis rubra pilaris. Very important, remember, these are also previous year questions. So we'll meet in the next video soon. Thank you so much. Happy learning. Bye bye. Sarvam Sri Krishna Param Sarvejana Sukhana Bhavantu.